we saw that including the cell therapy, I think all the cancer therapy, our medical oncologists especially focus on the solid tumor, is mimic the hematologist's cancer therapy method, because all the anti-cancer drugs somehow original from the hematological disease. So we think at first we just use or treat the solid cancer tumor, use cell therapy. We just learn a lot from our colleague, hematologist colleague, because we see the CAR-T may be the same, because the construction of the CAR-T or just the CRS reaction of the CAR-T, or just we detect the cytokine. At first, we all think so, including ours and hematologist colleagues. But we now think that this is totally different, including how we can evaluate the efficacy of our cell therapy in solid tumor, but how the CRS reaction, how to control. Also, we design the different way to make our cell therapy product just as compared to the hematological malignancy cell therapy. Including this, we also say that in hematological malignancy, so exciting, and just nearly 19% ORR to hematological malignancy, but in solid tumor, we cannot say how good the cell therapy efficacy was. But maybe even so high efficacy in malignant tumor after cell therapy, the patient still maybe needed to transplantation. So we thought there's so many trials and there's so many good efficacy has been shown in malignancy cancer after cell therapy, but they can make some very, very hard selection. So which trial to select for a hematological malignant patient. And in our solid tumor, we see some, you mentioned that another product, you can see CEA CAR-T or NKG2D CAR-T. You can also see some AFP targeted CAR-T. But some techniques also applied in this area. We have trial MSL and mesothelin CAR-T, although it's not broadly expressed in gastrointestinal CAR-T. I mention it because we have used this CAR-T and very specific technology. They can product a so-called bispecific antibody. They hope that the bispecific antibody to stimulate the CAR-T cell, or the so-called other not CAR-T cell, T cell in the body. So many techniques also co-stimulation and another target has been used in our solid tumor. But I think, just as Simon mentioned, although we can see very good efficacy in hematological malignant, but we will thought that the more applied area, or in other words, so many more solid tumor cancer patients will in unmet need for the emerging therapy, for example, our CAR-T cell. And not only CEA, not only EpCAM, our product, and not only NKG2D, the typical, or also we can see new antigen as a target. So many jobs, so many work need to be done to develop a more exciting and more efficacy and more safe cell therapy product to cure or to make survival benefit for our solid tumor patient.